Sure.
Chip program is developing in the United States. We have newsletters from that, but I think that it's only for the American doctors to attend the chip program. Is it true?
No, it has nothing to do with just American doctors.
I think that it's only for the American registered doctors. I'm not quite sure.
I think.
Does anybody know? Is anybody in Europe developing the chip program?
That I don't know. I can tell you that BioMime from mechanical support is supporting, courses and talks. I think chip is
okay, very good.
Is not just in the United States. Okay, Upendra, you're on.
Yes, Manish, it was fantastic listening to your talk, and I could not see the cases, but I could hear the description of the complex cases.
Well, we are
very
waiting
good.
to
I hope
hear
I'm
about
not
your
standing.
experience with BioMime.
Yes. Okay, I hope I'm not, standing in between lunch and
No, not at all.
the audience. Yes. Okay, so let me start. I'm going to give you a description and some experience with the BioMime family of Sirolimus-Eluting stents, and one of the trials comparing BioMime stent with Xience, which has been a market leader for many years. Now, the BioMime Sirolimus-Eluting stent basically, as you know, is a chromium cobalt ultra thin 65 millimicron metallic platform stent. It has a hybrid cell design. It has closed cells at the ends and open cells in the middle. The stent is mounted on a balloon, and the release system is very interesting. It is morphologically mediated. The middle part of the balloon expands first so that the stent is deployed in a way so that edges are expanded at the end, and that we believe reduces the chances of edge dissection. The stent is coated with a bioabsorbable polymer, which is a combination of PLLA and PLGA, and the polymer coating is very thin. It's only 2 millimicrons. It is absorbed within 2 months, and the drug is sirolimus in the dose of 1.25 millimicrons per millimeter of the stent surface. The advantages of this architecture are improved performance. The stent is very navigable, very well deliverable, causes less injury at the target site, side branch access is relatively easy, and it optimizes the procedure in many complex situations. And in view of the polymer and the drug concentration and the thin metal, the risk of stent thrombosis and restenosis should be pretty low. So let us talk about some of the scientific data on this stent. The first one is the MERIT-1 study, which was a first-in-man study done in 30 patients with single vessel disease, simple lesions, and it was done by Dr. Dani and his colleagues, published in Eurointerventions. It had excellent results. The late loss of only 0.15 millimeters, and MACE was 0. This was followed by MERIT-2, which was a multicentric study of 350 lesions in 250 patients with a 8 months angiographic follow-up, and we have 5-year clinical follow-up also. I was also a part of this study. The lesions were more complex, with 63% being B2 and C. The late lumen loss in the follow-up angiograms was very low, 0.12 millimeters, like any other good Sirolimus-Eluting stent. Major adverse cardiac event 6%, and target lesion revascularization rate was 5.2%, with a stent thrombosis rate very low, 0.4%. Then coming to Merit 3, which was again a multicentric study with more patients, around 1200 patients, 1 year clinical follow-up, with, like any Indian population, 40% diabetics, 1.1 lesion per patient, with a MACE of only 2.4%, and stent thrombosis hardly any, 0.1%, and a mortality of 1.4%. Now we come to the first study in which Xience and BioMime Sirolimus-Eluting stent has been compared, a randomized study with 2:1 randomization. BioMime 170 patients, 182 lesions. Xience 86 patients and 95 lesions, with a 9 months clinical and angiographic follow-up. Angiographic follow-up is available in around 90% of patients. This was a European and a South American study, and these are the names of the investigators from different countries. The inclusion criteria were maximum of 2 lesions in native coronary vessels, relatively simple, 1 lesion per vessel, reference vessel diameter 2.5 to 3, lesion length less than 46 millimeters, and total occlusions were excluded, so it was TIMI 1, at least TIMI 1 flow, and A, B1, B2, C, all lesions were included. We excluded patients from acute myocardial infarction within the last 7 days, ejection fraction which was low, less than 30%, ostial lesions, bifurcations where the side branch also needed a stent, and renal insufficiency with a serum creatinine levels of more than 2. The major study endpoint was an angiographic endpoint, that is in-stent lumen late loss at 9 months, and it was a non-inferiority study between Xience and BioMime. Secondary endpoints like acute success, MACE, stent thrombosis as defined by ARC, in-stent late lumen loss at 9 months, and restenosis rates at 9 months. QCA method was used, and it had a independent angiographic core lab in Sao Paulo, blinded to the clinical details, and standard QCA method was used for the analysis in stent, in segment, and also edges 5 mm proximal distal as is customary. The principal investigator of this was Alex Abizad. The baseline demographics, as you can see, they are quite matched. Like in any European population, the diabetes is not very high, 20 to 23%. Predominantly males, 70% are males, multiple risk factors, nearly normal ejection fractions, and majority of them had stable ischemic heart disease, with only 15% patients with unstable angina and around 10% with the previous MI. Pre-dilatation was done in equal number of patients in about 60%. Additional stents were used in less than 15% of cases. Post-dilatation was done in about 3/4 of the patients, and the final TIMI-3 flows were achieved in all the patients. If you look at the pre-procedure characteristics, more than 20 millimeter lesions, more than 20 millimeter length lesions were present in only 30% of cases, and the diameter stenosis was around 65% in both the groups. The post-procedure QCA, as you can see, the acute gain was equivalent, around 1.55. Diameter stenosis at the end of procedure was around 6 to 7%. with an acute gain of around 1.8 millimeters in both the stents. 9-month follow-up, as has been seen, diameter stenosis has been in the stent 8 to 10% in both, which is statistically similar. Percentage diameter stenosis at the follow-up is around 15 to 16%, once again similar. Late lumen loss, as you can see, is 0.15 in both the stents. In segment, proximal edge, distal edge, not very different. So both the stents behaved similarly during the angiographic follow-up. The cumulative frequency distribution, as you can see, the two curves are superimposed on each other with a late loss of 0.15 average in both the stents, which meets the non-inferiority criteria, and the sample size is not big enough to study superiority. Anyway, they are absolutely equivalent. Clinical outcomes at 30 days, no death, 1 myocardial infarction in BioMime and 2 in Sion, which is not different. No stent thrombosis at 30 days. At 9 months, the MACE are 5%, no death, no stent thrombosis. And as you can see, the Kaplan-Meier survival curves are again almost superimposed. So we conclude that the ultra-thin BioMime Sirolimus-Eluting stent has demonstrated efficacy on inhibiting neointimal hyperplasia, is very safe and as effective as Zion's in the daily practice. The Merit 5 study is the first randomized clinical trial comparing BioMime Sirolimus-Eluting stent versus the gold standard second generation market leader Zion's Sirolimus-Eluting stent. The overall results of Merit 5 were comparable with safety and efficacy, and also 9-month angiographic follow-up with Zion's. So these results, along with previous studies, may and should support a wider incorporation of BioMime Sirolimus-Eluting stent into clinical practice. And now Meril has come out with a stent called which is much thinner in strut thickness, is Evermine, which is only 50 millimicrons, and I have had a good experience with this, although we don't have a randomized trial data, but I think you can achieve similar results with thinner strut. Possibly if you have a large sample, possibly it might show some superiority over the Zion's and and the Sirolimus-Eluting Meril stent. Now let me come to the tapered and long drug-eluting stent. This has been one of the unmet clinical needs for several years, because if you have a long lesion more than 40-50 millimeters, especially the LAD tapers because of the branches. So if you go with the distal diameter, then you have to upsize the proximal part of the stent, and if you go with the proximal diameter, then the distal part of the stent may be oversized and may lead to problems. So very frequently what we do, we overlap the stents, take a smaller diameter stent for the distal lesion and a larger diameter stent for the proximal lesion, overlap them. Overlapping has its own problems, because it can lead to, in the overlap segment, rigidity. When you do a post-deployment high pressure balloon dilatation, you can produce a fracture. Restenosis theoretically would be higher in the overlap segment. There will be overdosage of the polymer as well as the drug. So excessive drug could theoretically lead to problems like late aneurysms. And then when you are using 2 stents instead of 1, your procedure time is prolonged, the radiation exposure is prolonged, the amount of contrast used is more. So it has all the advantages. So this stent, as you know, is called the BioMime Morph. It comes in 3 different diameters. Proximal diameter 2.75, 3 and 3.5. And then distally it tapers to 2.25 for 2.75 and 3 for 3.5. So basically this long stent is mounted on a tapering balloon. So it has the advantages of preventing an overlap and also maintaining the natural tapering of the vessel. Let me show you 1 or 2 cases if time permits. This is a 69-year-old female, multiple risk factors, who had a CTO of the LAD, normal ejection fraction, and the plan was to do angioplasty using the technique which one of the cases Manish showed, using the cross-boss and stingray, producing a controlled dissection and getting into the vessel. Now this is the still frame, right coronary artery on the left side, giving collaterals to the LAD. This is a CTO, and you can see a long segment. You can see the distal portion of the LAD from the collaterals. So the Conquest Pro wire has been used using the technique of which Manish already showed you. I am not going through the details of that, using the cross-boss and stingray to produce a entry going in sub-intimally and getting into the vessel. And then you can see this wire has crossed, and right coronary shot shows the distal LAD, that the wire is in the true lumen, and then a fine cross catheter is introduced, and the stingray wire is changed to a softer wire, and then the whole segment is dilated using sequential balloon dilatations, using non-compliant balloons. Long stent could not be advanced, so it is again dilated with a little bigger balloon. And finally, one had to use a guide liner, as you can see on the left panel, to push a BioMime Morph. This is 60 millimeters length stent, 3.5 proximally and 3 distally, and you can see the result, and then the proximal portion is again being dilated with a high pressure balloon, and this is the final result. So you can see left panel showing before the angioplasty and the right panel showing complete reconstruction of the vessel using a long stent with a taper, which is a BioMime Morph. Is there time for one more case, or maybe let's conclude it, because that would be a similar thing, because
Sure.
So long diffuse lesions can be better treated with single long stent. This minimizes the risk of fracture, possibly restenosis, and the associated ill effects of overlapping. They are also more convenient from procedural perspective. It also more cost effective for contrast, for radiation, and one stent instead of 2. Simultaneously, branching coronary stents tend to taper, and anatomically designed tapered stents may therefore provide to be better in stent conformability. So I think I've been asking the research department of Meril to have a randomized study of long lesions using a traditional, overlap technique versus a single stent with a morphologically tapering balloon like the BioMime Morph, and see whether in real life it makes any difference in the major adverse cardiac events. Theoretically it does, but one has to see whether in reality in evidence-based medicine it also does good.
It's a very good point.
Thank you very much. And
thank you, Dr. Kaul.
Thank you. Thank you.
So I have one question for you. Can you hear me?
Yes, I can.
So the Merit 5.
Yes, Manish.
The Merit 5 trial, which is
yes,
really important because it really does go up against what we think is the gold standard science platform.
yes.
Do you see
yes.
the BioMime and now the thinner strut Evermime? We're seeing shorter and shorter DAPT. Do you have any experience with short DAPT with BioMime? And if so, is that an important trial that should be done?
Yeah. That's well, it's not an experience in the form of a consecutive series, but then I have at least 30 to 35 patients in which we had to reduce it or stop the DAPT because the patient had to go for surgery which had not been envisaged when we did the PCI. The patients were only on aspirin. We stopped the clopidogrel part, and none of them had any problems when it was stopped at 3 months. So, but if we have a systematic, long-term, short-tap study, I think that would possibly be more convincing.
Any questions from the panel?
Yeah, it was one question about the design of the study. Is there any explanation why there was only 86 patients in the Xilinx group versus 170 in the BioMime group? And
it was 2:1.
Yeah, it's only
it
the randomization.
It's 2-to-1 randomization.
2-to-1. Oh, 2-to-1.
Yeah, 2:1 randomization.
And the second question is about the future. We always compare the new stent to the Xions, which to me is not probably yet the gold standard. So, as you said, it's probably time to compare this stent to the third generation of stent with a short DAPT, and this is how we can probably know exactly what will be the future for this new generation stent with 3 months of DAPT.
Yeah, I think the Merit 5 trial really showed nicely, really equivalence in late loss. I agree, small numbers of patients, but the proof of concept I think is important done with QCA. So, Dr. Kaul, thank you very much for your time. I know we're going to come back to you later this afternoon. I appreciate the time as always.
That's right.
And we'll see you in about 2 hours.
Absolutely. Have a nice lunch.
One question.
Yeah.
We cannot hear you. Can you
Achha,
switch on the mic, please?
Probably one question. I don't know whether they're asking me or Manish.
Yeah, just 1 minute. Are you asking for Dr. Kaul or Dr. Manish? Yeah. Okay, Dr. Kaul, that's for you.
Excuse me. If I am not mistaken, the TLR,
okay, good.
The TLR in the Merit 2 was more than 5%, which was considered most of the observed MACE. But in the Merit 3 study, it was only 0.5%. How can this difference be explained?
Well, there are two different populations. The Merit 5 had a core lab and, done much more scientifically. Merit 3 is just a registry, post-marketing registry. So if you are analyzing your own results, you may be different. And Merit 3 had 41% diabetics, whereas the Merit 5 had just 20% diabetics.
But the observed TLR is much less in Merit 3.
Yeah, that's what I said. Yes.
And as a comment,
difficult to explain because, these are not comparing the same populations. Yes. Yes.
And as a comment, and I agree with you, we recently submitted a study from Tehran Heart Center, a comparison between ultra-long BioMime stents with overlapping traditional well-regarded stents, for example, other brands.
Okay.
And, we performed this study in 260 patients because the only long stents that are available in Iran are BioMime, but many physicians hesitate to use these stents because they believe that these Indian-made stents are maybe inferior to other well-regarded stents. Our results shows that the MACE and any clinical outcome are similar between these two groups, but as you know and as you say, the fluoro time contrast dye used and the cost of the procedure was very lower in the single stent. Thank you.
That's very good. Excellent. Thank you very much, Dr.
So I think
Kaul,
that
at
least is a good advantage. Yeah. Thank you. Yeah.
So before we go for lunch break, I would like to invite Dr. Nick Palmer from UK to talk on my most complex and educational cases. Thank you.